Hello, learners. Welcome to Lecture 19. In the last lecture, we discussed the critical role of community health workers in implementing RCH services. Today, we turn to public private partnerships or PPPs in reproductive and child health. These PPPs have become increasingly important in bridging gaps in infrastructure, financing, and service delivery. This lecture will explore the concept, rationale, models, examples, challenges, and future scope of public private partnerships in reproductive and child health. By the end of this lecture, you should be able to explain what public private partnerships are, why they are needed in health, and specifically how they function in reproductive and child health services. We will discuss different models, Indian examples, and assess the strengths and weaknesses. Finally, we will explore what more is needed and what can be done to strengthen these public private partnerships for RCH outcomes. A public private partnership is defined as a structural collaboration between the government and the private sector, where resources, risks, and responsibilities are shared. The ultimate goal is to deliver public health outcomes more efficiently. Public private partnerships are formalized through contracts or agreements, ensuring accountability on both the ends. The rationale for public private partnership is clear. The public sector faces constraints in infrastructure, financing, and human resources, while the private sector brings efficiency, innovation, and outreach capacity. These PPPs leverage the strengths of both sectors to expand access, improve quality, and accelerate progress, forwarding towards universal health coverage. PPPs are particularly relevant to RCH because maternal and child health still accounts for significant share of India's disease burden. Service gaps persist, especially in rural and remote areas. Families face high out of pocket costs, and public facilities are often overburdened. These PPPs can improve availability and affordability of contraceptives, maternal, newborn, and child health services. Well designed models include contracting in obstetricians and anesthetists for C section and emergency obstetric and neonatal care. Ambulance partnerships for timely referrals and diagnostics, blood bank partnerships to reduce the second and third delays. Supply side partnerships like social marketing, franchising of contraceptives, last mile cold chain, and pharmacy tie ups. They stabilize commodities and widen the method basket. Demand side approaches like vouchers, PMJ, empanelments, transport, cashbacks, they lower costs and pull poor families into quality facilities. Contracts should be performance based with clear clinical standards, price caps, zero denial call clauses, and grievance redressal to protect rights. Digital claims audits and client experience feedback curb overuse and fraud while rewarding respectful evidence based care. Crucially, public private partnerships must complement, not replace, public capacity with government stewardship to ensure coverage to hard to serve geographies and populations. There are multiple models of public private partnerships in health. Contracting out involves outsourcing specific services to private providers, useful for emergency obstetric and neonatal care diagnostics, blood banks, or ambulance networks like 108, 102 when public capacity is thin. Social franchising creates networks of private clinics under a common brand with standard treatment guidelines and quality assurance, effective for family planning and RMNCH counseling. Voucher schemes. They subsidize the services for clients through private providers, targeting poor or adolescent girls to reduce out of pocket costs and encourage timely care. These public private partnerships also extend to infrastructure development and joint ventures for hospitals or supply chains, improving cold chain, lab, and logistics reliability. Each model has distinct strengths and limitations. Contracting can scale quickly but needs strong oversight. Franchising builds quality but requires sustained support. And vouchers reduce financial barriers but demand robust fraud control. Success hinges on clear clinical standards, capped prices, zero denial clauses, grievance redressal, and equity linked performance indicators. Government stewardship is essential, so these partnerships complement and not replace public services, prioritizing underserved geographies and populations. Contracting out is common partnership approach in RCH. Governments engage private hospitals, maternity centers, or labs to provide specific services such as deliveries, C sections, or diagnostics. These are often performance based contracts tied to outputs. This approach increases service availability in areas where public facilities are limited. Social franchising involves enrolling private providers into a franchise network where they deliver standardized, quality assured RCH services. In Bihar, the Janani network is a well known example offering family planning and maternal services. Franchisees are trained on clinical protocols, counseling, infection prevention, and respectful care. And they receive branding, job aids, and supportive supervision to keep quality consistent. Central procurement and negotiated prices stabilize commodities and keep client fees predictable, improving affordability and trust. Networks often link with government schemes like vouchers, JSY, JSSK, or PMJ, so poor clients can access services cashlessly and referrals from ASHAs convert them into timely care. Routine reporting, client experience feedback, and periodic audits maintain standards and allow quick course correction. Because outlets are closer to where people live, social franchising extends reach to peri-urban and rural markets while preserving a recognizable quality seal. Equity must be guarded through pro-poor targeting, clear price caps, and of course, as previously discussed, zero denial clauses to prevent the drift towards the paying clients. As we know, the sustainability will always hinge on steady supervision, commodity supply, and fair reimbursement, so franchisees remain committed without compromising the quality of services. Voucher schemes they empower clients by giving them vouchers to access specific services at private facilities. This ensures choice and reduces financial barriers. Gujarat's Chiranjeevi Yojana used vouchers to cover institutional deliveries for poor women in private hospitals. This model improved equity and increased institutional deliveries significantly. Infrastructure public private partnerships involve joint efforts in building and operating facilities. Private partners finance, construct, and sometimes manage hospitals or maternity units under long term contracts. This model addresses shortness of physical infrastructure, especially in underserved areas. It requires robust governance and accountability mechanisms. Joint ventures involve public and private entities co owning and managing services. This could include diagnostic centers or specialty hospitals. Collaborations also extend to research, training, and technology development. Joint ventures strengthen integration of private sector expertise with public health goals. The Chiranjeevi Yojana in Gujarat is a landmark public private partnership. It was launched in 2005. It partnered with private obstetricians to provide free institutional deliveries for poor women, with the government reimbursing providers per delivery. Targeting the backward classes, scheduled castes, scheduled tribe beneficiaries, the scheme used a simple card or voucher and fixed package rates that covered normal and complicated births, thereby eliminating point of care charges. Contracts required 24 into 7 availability, adherence to obstetric protocols, clear referral linkages, and reporting for audit. This helps standardize quality. Integration with 108 ambulance services and blood bank networks reduced second and third delays and protected women from catastrophic expenses. Evaluations showed substantial increase in institutional delivery among the poorest quintiles and declines in maternal and neonatal deaths. Key lessons include set transparent package rates, enforce zero denial and grievance redressal, and track equity indicators to avoid cream skimming. The model demonstrates how performance linked contracting can rapidly expand emergency obstetric and neonatal care access while complementing public capacity in high need areas. The Janani program in Bihar is a successful social franchise model. It created a network of private providers delivering affordable family planning and maternal services, with standardized protocols to ensure quality and client safety. Franchise outlets received training, branding, supervision, and centrally procured commodities like IOCDs, OCPs, injectables to keep prices predictable and stock reliable. Linkages with ASHAs, vouchers, JSY, and referral pathways helped poor and rural clients access services cashlessly and on time. Routine audits, client feedback tools, and complication reporting maintained accountability and respectful care. Outreach and IEC through the franchisee brand increased awareness and trust, particularly among first time parents and adolescents. Independent assessments reported higher contraceptive uptake, safer deliveries, and reduced out of pocket expenditures in underserved blocks. This model shows how franchising can extend reach while protecting quality provided price caps and equity targets and robust supervision are sustained. In Madhya Pradesh, safe delivery voucher schemes were implemented to promote institutional deliveries. Women received vouchers redeemable at accredited private facilities, which increased institutional deliveries and gave clients more choice in where to seek care. The program targeted poor and high risk pregnant women. Ashas and ANMs identified the beneficiaries, issued the vouchers, and facilitated transport to empaneled facilities. Private hospitals were accredited against clear emergency obstetric and neonatal care standards. Package rates were pre negotiated, and zero denial price cap clauses protected clients from out of pocket costs. Claims were reimbursed digitally after verification of partographs, discharge summaries, and newborn outcomes. aligning private providers with public reporting and quality norms. IEC campaigns and helplines informed families about eligibility and grievance redressal, while audits and client feedback tools deterred overuse and fraud. The scheme stimulated private facilities to upgrade skills, infection control, and referral linkages with blood banks and 108 ambulances. Key lessons: keep eligibility criteria simple, ensure timely reimbursement, monitor equity indicators, and integrate vouchers with JSY, JSSK so benefits are seamless for mothers and newborns. The private sector has contributed significantly to immunization through cold chain support, logistics, and CSR led campaigns. Corporate hospitals and companies often support immunization drives in urban slums, supplying vaccine carriers, ice packs, and vehicles that extend outreach to hard to reach areas. Many partners co finance the last mile distribution and temperature monitoring, reducing stockouts and cold chain breaks. CSR foundations fund microplanning, community mobilizers, and social behavior change activities that identify and convert zero dose and dropout children. Private labs and hospitals strengthen AEFI preparedness with on call pediatricians, emergency kits, and referral linkages, while helping with reporting and real time dashboards. Workplace clients in factories and construction sites bring routine vaccination to migrant families who often miss the fixed sessions. To protect equity and quality, partnerships should use government price caps, standard operating procedures, and joint supervision with the UIP team. Done well, these collaborations complement, not replace the public services, expanding reliable, safe immunization to underserved urban and peri-urban communities. Private sector partnerships have long supported family planning through condom and pill social marketing, often use commercial networks like pharmacies and shops. Franchised clinics also provide sterilization and spacing methods. These partnerships expand contraceptive choice and access, especially in urban and peri urban areas. Non governmental organizations, or as we call them, NGOs, are vital public private partners in reproductive and child health. They deliver services in remote or marginalized communities, conduct behavior change communication campaigns, train health workers, and advocate for policies. NGOs provide flexibility and community engagement capacity, often lacking in the public sector. Faith based organizations also play a significant role in reproductive and child health. They run hospitals, maternity homes, and community programs, often in underserved rural areas. Their trust and credibility in community help improve service uptake. These organizations often target health and education and social services, providing a holistic model of care. The corporate sector contributes to reproductive and child health through corporate social responsibility or CSR initiatives, including subsidized services in hospitals, funding government programs, organizing health camps, and deploying mobile clinics. Companies partner with the National Health Mission and state health societies to co finance reproductive, maternal, newborn, child, and adolescent health outreach, procure equipments, and upgrade labor rooms and newborn care units. Corporate hospitals provide pro bono or low cost antenatal care, safe delivery packages, postpartum contraception, and newborn stabilization, with referral linkages to 108 emergency transport and blood banks. Many firms underwrite behavior change campaigns or menstrual hygiene, nutrition, and family planning, and sponsor training for ASHAs, ANMs, and Anganwadis, including counselors. Mobile medical units and workplace clinics reach migrant workers and urban slums for antenatal care, postnatal follow up, and immunization under the Universal Immunization Program. Transparent memorandum of understanding with quality standards, price caps, and client protection clauses keep services equitable and rights based rather than promotional. Joint monitoring dashboards, adverse event reporting, and client experience feedback align the CSR projects with district microplans and prevent duplication. Public private partnerships offer clear benefits in RCH. They expand access to underserved population, improve service delivery, service quality through private sector standards, and mobilize additional resources. These partnerships also bring innovation and efficiency, such as modern supply chains or new service delivery models, strengthening the overall health outcomes. Despite benefits, public private partnerships face challenges. Ensuring quality of care in public facilities is difficult without strong regulation. Monitoring and accountability systems are often weak. There are concerns that PPPs may exacerbate inequities if they favor wealthier groups. Sustainability of these models is also questioned when donor or corporate social responsibility funding declines. To mitigate these risks, government needs clear service contracts with standard treatment guidelines, zero denial causes, price caps, and patient rights protection, backed by independent clinical audits and grievance redressals. Digital dashboards that link claims, outcomes, and client experience data can strengthen real time supervision and detect fraud or overuse. Equity must be explicit. Empanelment in underserved blocks, voucher or Pradhan Mantri Jan Arogya Yojana coverage for poor households, and performance indicators disaggregated by gender, caste, creed, tribe, rural, urban status to ensure the partnership advances universal health coverage rather than deepen the gaps. Ethical concerns must be addressed in PPPs. Patients' rights must be protected, avoiding profit driven exploitation. Transparency in contracts and processes is essential. There is always tension between public health goals and private profit motives, and careful regulation is needed to maintain balance and protect vulnerable populations. Effective regulation is crucial for successful partnerships. Private providers must be accredited and licensed. Standards of service quality need to be enforced. Independent monitoring mechanisms, along with grievance redressal systems, ensure accountability. Without strong regulation, these partnerships risk compromising public health objectives. Monitoring and evaluation of these partnerships requires robust systems. Performance indicators such as coverage, quality, and client satisfaction must be tracked. Third party evaluations provide independent assessments. Digital health tools can improve data collection and monitoring. Continuous feedback ensures corrective action and long term improvement. Globally, these partnerships in health take many forms. The UK's NHS contracts private providers for specific services. Voucher schemes in Africa have expanded maternal health access. Southeast Asia has used social franchising for family planning. These experiences offer lessons in India on designing and regulating these PPP models effectively. These partnerships also contribute directly to SDG agenda. SDG 3 emphasizes health and well-being, while SDG 17 calls for partnerships to achieve the goals. Private partnerships foster cross-sectoral collaboration, essential for scaling health interventions. They are increasingly recognized as key to achieving universal health coverage. Innovative partnerships with private organizations are emerging in India's health sector. Mobile health vans and telemedicine partnerships expand reach into underserved areas. Digital payment models ensure transparency and efficiency. Cross subsidization schemes allow the private sector to serve poor clients while sustaining profits. Such innovations make public private partnerships more inclusive and sustainable. Future directions of these partnerships include stronger regulation and governance to ensure accountability. Successful models like Chiranjeevi Yojana should be scaled up. These public private partnerships can be expanded into new areas such as adolescent health and nutrition. Equity and community participation must remain central, ensuring these partnerships serve the most vulnerable populations. Key takeaways from today's are that private partnerships leverage the strengths of both public and private sectors to improve RCH outcomes. Models include contracting, franchising vouchers, and infrastructure partnerships. Successful Indian examples demonstrate their potential. However, regulation, equity, and sustainability are ongoing challenges that must be addressed for PPPs to succeed. This concludes today's lecture on public private partnerships in RCH. Alongside earlier lectures on maternal, child, family planning, adolescent health, and community health workers, this, lectures, this lecture adds another dimension: partnerships beyond the public sector. Today, I encourage you to reflect how these public private partnerships can complement government efforts while ensuring equity and accountability. Next time in Lecture 20, we cover monitoring and evaluation of RCH programs. Thank you all for today.